The content of this podcast is for informational purposes only and should not be considered medical advice. Always consult with a qualified healthcare professional for any health concerns. Take care of yourself out there.
Welcome to Unravelling. This is a podcast that sees the world through the lens of mental health. I'm Mary Wilson, a journalist.
And I'm Kurt White, a social worker and psychotherapist. A few episodes ago, Mary, we started to talk a bit about bipolar disorder by getting into it with Peter Mendelsohn and Betsy Lerner. Some of their creative works had been influenced by their personal experiences with that particular psychiatric illness. And it's a complicated one. It involves phases of mania or hypomania, as well as phases of depression, which can be deep depressions or less deep. And I think it's one of those words that's out there in the world, but which I don't know how much people really understand about that.
I think it's very misunderstood. The portrayals in media are sensationalized. And before listening to today's interview, I knew about the highs and the lows and mood swings, mania, depression, but I didn't really know, what that looks like in real life.
Yeah, I think it is really misunderstood, and it's not that unusual, I would say. It might be less common than something like a sort of unipolar depression, we would say, where a person just gets depressed, but it's a thing that we see a lot in intensive psychiatric settings. It's a reason why people get hospitalized, need hospitalization sometimes, and it can look kind of dramatic in some parts of the illness, and it, in other times, might be really quite invisible to others, like when folks are withdrawn and depressed. We had the thought it would be great to get somebody who really does that kind of work, works with folks like that in a day-to-day way.
Yeah. And so you were able to speak to our colleague, Matt Dove, who works here at the Brattleboro Retreat.
Matt Dove is a duly certified nurse practitioner in family medicine and psychiatric mental health. He's studied at multiple universities, Shenandoah University, Johns Hopkins School of Nursing, Chamberlain University, Maryland University, has done work, as I mentioned, in lots of different intensive settings, and in general is just one of the smartest, kindest, and most interesting people that I know. So I'm really happy to bring this interview to us today.
All right, let's listen in.
So, Matt, welcome to Unravelling.
Thank you so much for having me.
Now, we've known each other for some years and have worked together on various projects, often involving folks on the more complicated end of the mental health diagnosis spectrum. And there's a lot of room on that complicated end. But one thing that comes up a lot and is sometimes talked about in popular culture and imagination is this bipolar disorder, formerly called the manic depressive illness. People might have heard that. And I was hoping that today we could have a conversation about that and try to unpack some of what that really is, and to sort of maybe untangle some of the myth from reality in it.
Yeah, and I just want to first start by saying thank you so much for to you and Mary and the team here for how you approach thoughtful conversations about complicated psychiatric care need ideas. And so I've been kind of listening to the show itself, and I know there's been some conversations about bipolar before this, and I just think that it's exactly right. When you first approached me about this, you were like, well, we've done some other things talking to folks that have been kind of in artistic endeavors and have spoken their story. And I was like, that's exactly right. That we lead with the person, and then we kind of look at the clinical details maybe as a second thought to that experience, right?
We recently talked to Betsy Lerner and Peter Mendelsohn, who were very candid with us about speaking about different phases of their own bipolar illness, the depressive, really, and Peter Mendelsohn's discussion and writing, and Betsy Lerner, a bit of both, but really focusing more on the expansive and manic parts of that illness. And I thought, well, this is sort of leading us to sort of how can we get at what this is. So maybe that is a starting question. What do we mean when we say bipolar disorder?
Yeah, I think over time, diagnoses have evolved, particularly for this idea. And like you said earlier, it was initially thought as a mood swing. I was always taught, and it was a very crude and oversimplified idea of like a gas gauge or fuel gauge of like empty means that you've experienced a depressive episode, and then the full gauge is when you sort of are in a more manic state, a more heightened state. I think that there's absolutely gradient and spectrum to that, but that was kind of the polarities that I learned about initially were that manic phase and that depressive phase. We've realized through better understanding of the brain itself is that this is a much more complicated kind of experience that I almost look at as like a temporal disease or a need. It affects energy levels, it affects cognition, it affects basically sleep cycles and other things that are not just mood.
Yeah. And depression, I think we probably have a better sense of culturally and socially. Partly it's a maybe more common problem. It can show up in lots of ways. Although even then, I mean, do we know that one person's depression is the same as another? Hard to know. But generally speaking, something with bad feelings, trouble sleeping, lack of interest in things, lack of pleasure from things, sometimes a wish not to be here anymore. Those are common things with depression. And if that's the low, what is this high part of it?
Yeah, I think, when we look at the American Psychiatric Association's kind of definition and we look at like rudimentary DSM criteria for the most current version, we look at ideas of like at least an episode of mania for bipolar 1 disorder. And then those are characterized by at least a week of that period, not just kind of like, day to day kind of feeling low or feeling high. It's a sustained period of labality is how I describe that. And then a duration that could have functional impairment. And so within mania, you have certain characteristics or what we call symptom constellations. And they include like grandiose ideas of self. They include like decreased need for sleep, impulsiveness or risky behavior is what they would define that as. And then pressured speech, the way we talk, changes from what we normally would have in typical conversations. And then the other one idea is like a flight of ideas, they sometimes describe it. And then sort of in a most severe space, mania can go towards psychosis.
Could you give some examples of what that might look like?
Yeah, I think what happens a lot in mania is that it can be like this sort of at first this transcendent, creative, almost chosen experience for the person that is living with it, and it can look very different for different folks. And we understand multiple kind of what we describe as delusional elements, which are fixed false beliefs, so non-consensus reality. Some of those can be somatic, believing something that's happening to your body that might not be occurring in reality. A common one is being infested or feeling like you've gotten something in your body that might not be there. Sometimes they used to call them erotic mania ideas of like love or belief that maybe someone that is a celebrity is in love with you, or that you have a relationship that might be overextended, that it's not really the same relationship to the other person. And then there are times are religious delusions, and they're culturally bound, of course, for the person that's experiencing them. And so sometimes people have a belief that they're a deity or someone that's really important in a religious doctrine or dogma. And so you can really have this like inflated sense of self. And those moments are difficult to like have self-awareness or insight in.
Mm-hmm. Yeah, when people feel good, they don't always seek treatment for that, in other words, right?
That's right.
It's like feeling good is good a lot of the time.
Yes.
Yeah, well, and sometimes people, when you get into a very expansive mental state, people start to do things and make different decisions than they would in a more typical state of mind for them, right? Now, maybe you could say that it's not necessarily reflective of illness sometimes, depending on, a psychiatrist once told me about a person that bought 12 cars in a day, right? That's probably not great for most people. I mean, if you're a billionaire, maybe you can get away with it, I guess, right? So it's a little contextual, but for most people, that's probably gonna be bad. But what about the person that decides they want a new car, even though they wouldn't normally be doing that right now? They're just making different decisions, but they're not necessarily, And I think that's part of what makes it hard sometimes to sort of where to draw that line.
I would agree. And these are the moments where we look at things like hypomania, and we even have modifiers to the diagnosis of bipolar. There's a bipolar 1 where we typify one episode of mania as the major distinction between that and bipolar 2. And so bipolar 2, I think of two moods with that. Obviously people experience more than that, but I think of hypomania and I think of the depression as well. And so the hypomania can be what you're describing is that it's just a different way of being in the world that they would not have typically chosen for themselves.
Mm-hmm. Mm-hmm. Yeah. But others might notice it, for example, right? You might show up to work and seem a bit different in that way. So it might come to others' attention before maybe it would ring true as a problem or a symptom or something like that for an individual.
It's very accurate. I think there was a poet, Robert Lowell, and he described depression as my illness, and he described mania as everyone else's illness. And so the manic phase for him really was about, going in the middle of the night and waking someone up and saying, I just wrote my magnum opus, or I just did this thing, I bought this car today, right? And so you're exactly right. It can be very visible and loud, and that's oftentimes where we start to see the distinction and movement in a different way towards treatment. I think that there's a delay in diagnosis of bipolar disorder pretty commonly of 7 to 8 years. And a lot of it has to do with we are very attuned to depression. Sometimes I often hear is the person says, I've been taking all the different antidepressants and they just make me angry, or nothing really is working. And so there's the moment where you imagine diagnostic clarification might be useful here, and that might be a real bellwether sign that we're talking about a different mood spectrum altogether, a bipolar disorder.
So let's get into a little bit what this diagnosis looks like in its different permutations. I guess I was taught that there's a kind of a textbook version of this, the old-fashioned bipolar, you might call it that, or something like that. Not that it's just because it's been described like this for a long time. And that would be a person who, when they're doing well, is doing well. They're neither depressed nor manic nor hypomanic, which is a little bit manic, and they're bebopping along their life roughly the same way everyone else would be. But then you have episodic experiences of depression and or mania or hypomania that could be years apart. Right?
Yeah.
Right. I mean, that was the classic picture. You might have relatively few of those episodes over a lifetime, but they're really severe peaks and valleys, right?
They used to describe it as bimodal in the literature, and you'd see it in periods of vulnerability, maybe in the teenage years or 20s, and then kind of you would see maybe a treatment episode, or you would see a dormancy, and then you'd see it again maybe a decade later. But you're right, these were the classical versions of that.
And that's one obstacle to diagnosis, isn't it? That even if you've had an episode of mania, sometimes if you're not presenting that way and even just describing it to a psychiatrist, even I've had people, the psychiatrist say, well, they sure don't look manic to me, And I'm like, well, they're not, because they're not in a manic episode right now. But boy, when they were, right? Everyone would agree. And so things that are kind of longitudinal like that, where they show up intermittently over the course of a person's life, those are almost always harder things to diagnose, aren't they?
Yeah, and I think that's what, like longitudinal kind of, this is where your history becomes so important, and really understanding that temporal course, even just like writing it on a, like a calendar or something, really understanding that differently, because you're right. Like, this is what I think one of the challenges to diagnosis can be, is like, unless there's someone that's in front of you that's clearly manic, it's hard to really like differentiate in ways. And this can be like the kindling effect, as they describe, right? Like this untreated mood spectrum, particularly like mania. I kind of talk about with neuroplasticity is like what fires together wires together. And so if people are not getting the right diagnosis or the right treatment at the time, we are forming neural connections that can be maladaptive in ways.
Yeah. What about maybe a more complicated picture where people don't necessarily, maybe they have more frequent episodes or more frequent movement between manic and depressive and hypomanic episodes, or where they don't get the easy full remission that I'm describing here? Why does it sometimes look like one thing and look like another thing?
Well, there was this really interesting study last year from molecular psychiatry, and it talked about kind of what you're describing, and like there's just such a genetic architecture that we don't fully understand. And so part of that really is that we have these, like what you described, like polymorphisms or permutations on the genetic expression. And over time they accumulate and they just look different. Like they have different phenotypes or different presentations for each person. I mean, there's a high heritability to it too. And you've talked about that in like generational kind of traumas and generational kind of things that are happening for folks. And so I think there's a lot of environmental factors, a lot of genetic factors, and a lot of, personal factors. Certainly like substance use comes into mind. Like maybe I'm feeling this a certain way, and substances are important for treating it on my own. Maybe I don't know what's going on, and I just know this helps.
And there are things, both sort of prescribed pharmaceuticals as well as things people use on their own for various reasons, that can make things potentially worse in some folks, right? I mean, notably in particular, certain classes of antidepressants can sometimes...
Yeah, absolutely. Right. Like this is something that really comes to mind when I'm getting a history is, I've been given Lexapro, or I've been taking sertraline, and I noticed that like I have all types of energy now, and people are saying like you're really talking very fast, and so they can really activate those pathways like dopamine and serotonin that are the same intrinsic circuits that mania works on. Stimulants can certainly put a lot of dopamine into the brain and react differently for someone that experiences bipolar disorder than ADHD. And it can be difficult, like you were describing diagnostically, because there is this polyphyletic kind of process where symptoms overlap, distractibility, attention. This is where I think the rigor of the diagnosis is needing a little bit more oomph, is to really kind of differentiate the two. I think time is an important element for bipolar disorders like you're describing.
Yeah. So there's an overlap of, there's only so many things that right, a depression makes concentration bad. So can mania make concentration bad, right? We are very different things. So can ADHD, so can PTSD, right? And so there's only so many mental functions we can observe at once. So we have to look at them kind of in combination of the total picture and what's the thing that fits the best. And
right.
Or do they have more than one thing? That can also be true, right?
That's an important distinction. The dialectic of they both could be existing in a person's profile.
Yeah, Hickham's dictum. Yeah.
Yes.
Yeah. A man can have as many diseases as he damn well pleases.
Yes.
Yeah. But how do you tease those things out? Are there particular kinds of things you look for as a sort of clinical expert with a lot of experience?
Yeah, I mean, this is where the art comes in. I mean, we're not treating strep throat here, right? Part of our work is not just saying like, here's a medication and I hope you get better. It's really understanding the emotional and the experience, the expression of that for them. Why maybe medications have been something they don't enjoy, like the cognition factor. Like, is this going to change me? Is this going to change how I become creative in the world? Like, these are questions that I get asked a lot. So it's not just about like the clinical symptoms. It's really about the expression of the illness itself for the person and how they've kind of worked in the past with what they know to be true.
You see, I think I always At some point along the way, I developed a kind of I don't know, it's not exactly a litmus test, but if the person isn't having at least some decreased need for sleep, I very often think it might be something other than a manic episode. That one is so particular, and there aren't nearly as many things that make you not need sleep, right? You can have insomnia, but not need it. That often for me has been a hallmark symptom.
It's a huge part of mania, and it's a huge thing that we target when we start to acutely treat mania, is trying to get people as much sleep as possible. Because you'll hear stories of, I wasn't sleeping for 7 days, and sometimes people are like, this was great, I was trying to get something done and it was very helpful. But like you said, it really is a hallmark of an acute phase of mania. Yeah.
And it's interesting because we do talk about it as a mood disorder, but actually, we've already said that it can have significant impacts on a person's thinking and thought process, right? It can overlap with even thought disorders, right? And bringing you into feelings or experiences, rather, of psychosis, where maybe it's harder to distinguish what everyone else agrees is reality from what you think is reality. I remember one person, and this is a true story, came in to my office, and he was doing mental arithmetic in his head so quickly that he could not, I later learned, could not normally do. He could only do this in a manic episode. So he would take words and phrases and associate it with the letters, like A is 1, B is 2, C is 3, and so on. And he would add up the total of all the numbers and then mentally compare them to other words and phrases with similar or the same total, and then draw meaning from the similarity or difference in the total. And afterwards, I almost didn't believe it, because I could see him doing it in real time, and I had to make a graph and count it out and add that. I had to know. And I'll be damned, he was spot on every time,
Yeah.
And so what is that, is that it is kind of like this feeling to me like people's everything is sort of like the throttle is wide open.
Yeah, I mean, I've heard it referred to as superpowers and things, and I don't know that I love romanticizing these moments for folks. I think that it's important to recognize that there is distress to it too, but I certainly can appreciate that it's a complicated kind of conversation of people are having more amplified experience. I heard a story once of a person that had 1,000 patents at one point in time, and they were given the charge by Mercedes that they couldn't build a particular car this long or add double wheels, and they took it as a challenge, and they did it. And it really was this visual representation of the expansiveness that you're describing, and certainly there's a lot of literature that talks about creativity and how people are fearful to remove themselves from mania because they worry they won't be as good of an artist or they won't be as creative. And for me, it's important to kind of recognize that it's not always what you're describing, right? It can just be pages and pages of information, that hypographia that's not really sensical. It's not really information at all.
It doesn't make sense. It's
right.
not. Yeah. I had been more skeptical of that creativity link in that way, because I think a lot of the creative people that I had known, there was a real kind of, nose to the grindstone quality to their creativity. They had to really, lean into repeated efforts of doing something. It didn't necessarily have a magical muse kind of quality to it. Although I have come to feel that there probably is something to it, especially maybe in a particular narrow band of increasing hypomania or something that sort of potentiates some maybe disinhibited potential. Like you're going to write that book, What's Getting in the Way? Well, if something all of a sudden, nothing's getting in the way, maybe you do it, right? And then I have experienced people have that, but then it often gets disorganizing.
Right. Yeah, we can recognize there's extraordinary shifts in the human consciousness, and maybe they're unlocking something that, like you said, was inhibited before, and now it's open. That risk taking is really just writing that book now, and I can appreciate that.
That same person later on, when they were getting more well asked me if I thought they had been manic. And I said, yeah. And he said to me something I never forgot, which was, he said, it's so much harder to be depressed than to be manic, but it's much worse for someone to tell you that you were manic than for someone to tell you that you were depressed.
And you bring up the really important point that this is devastating. This is a really life-altering, like the World Health Organization talks about, like its prevalence is like 1% in the worldwide population. So I think that's about 40 million people, and how much it's a leading cause of disability early in life. What you're describing is really a key here, that this is a very deadly disease ultimately, right? Like that people do kill themselves. This is a very real stakes of this disorder. Like I've gone from this very significant high to this very significant low, and neither of them really, at a certain point, some people recognize that it's not working for me. And so this is where things get really insidious and dangerous.
And the depressive states are also particularly awful for folks I've known any number of therapists and psychiatric prescribers, psychiatrists and others that have said that there's really no depressed state worse than the depressed state that follows a manic episode. And what is it about that is so particularly devastating?
I mean, it's kind of what we were describing, is like you are in a place where you might feel incredibly special, or that this is your best self, that you're in a heightened state that you lose. And then on the other side, I think the sort of sophisticated perspective that most people have taught me is that you spend a lot more time in a depressive state than you do in the mania. And I can only imagine the like intoxicant of that phase, and then losing that phase and having to kind of be back to this sort of like reality, but at the same time recognizing that there could have been some broken relationships, some relational ruptures. There could be financial consequences. There could be sort of like all sorts of dynamic things that happen to you while you're in the manic phase, that now you're kind of like recognizing you have to, like legal trouble, things that you could have to kind of appreciate when you're in a depressive phase.
How do you treat this disease, both in the manic and depressive phases of this? Like, what is it? Is it medicine? Is it therapy? What does it look like?
Yeah. I mean, Hippocrates talked about this, right? And he did a pretty good job of describing mechalalia, the melancholy and the depression. And he talked about the prognosis was things get worse and people often kill themselves. And so, like, the state of the science now is that we do have treatable, like, interventions. And I think that what you described is really, kind of where we are in 2026, is that we can offer both pharmacological and non-pharmacological elements. In acute phases, I mean, it's really interesting that we, 75 years later, go to a body salt, which is lithium. Lithium remains a standard of care for people experiencing both mania and depression. And when we talk about suicide, it does have anti-suicide effect as well.
And that was discovered quite by accident by an Australian World War II veteran who was doing his own experimentation with literal guinea pigs and probably poisoning them. But but it turns out he was onto something.
Did you know that it was in soda in the 1929?
Yes, lithinated 7-Up.
7-Up, yeah. And it's called 7-Up because 7 is the atomic weight of lithium, isn't it, on the periodic table?
Oh my goodness, I did not know that. Of course, that would make sense. I love that.
Yeah. So, and again, like, we don't really quite understand what lithium does. There's some interesting stuff from, oh goodness, I think it's like Molecular Psychiatry Journal last year talked about mitochondria. And they were saying that, this energy reserve, the ATP, might be why lithium works. It works on the mitochondria, the cellular energy.
Wow, the powerhouse of the cell.
Powerhouse of the cell,
yeah. We remember that from biology. Absolutely, yeah.
But there's some evolutionary thought of, like, these are just variations of normal sleep-wake cycles, right? Like mammals have hibernation states, and so there's benefit to slowing down in these seasonal kind of experiences with winter, and then revving up during warmer times.
I was taught that in the acute phase of mania, that like in a hospital setting, the most important thing to do is to get folks to be able to sleep again.
Right.
And that the sleep is part of what actually brings people out of that state. Is that how you see it?
That's how I understand it, and how I've seen it happen in clinical practice, is that, someone would come into the hospital and it can be a messy phase where we're adding even antipsychotic medications, mood stabilizers, sleep medications, really to get the person into a kind of a state of sleep to help limit the mania. To sometimes they call that breaking. I don't love that term, but
yeah. And there's a couple different categories of those medicines, but they're all trying to do the same thing in those phases of things, kind of bring a person out of this very expansive state. And they all have some pretty significant potential side effects, at least, that have to be watched, right? I think it's...
Yeah, I mean, lithium has its own monitoring. Certainly the amount of fluid you're taking in, how much you're sweating, if you're having, illness, your kidney function. These are really important things to know about. And then, with the antipsychotic class, there's different generations, and those have their own kind of profiles, metabolic side effects, sometimes movement side effects. But, again, these are medications that have been prescribed for many years, and we're well aware of what they can do for people. And the most important thing is that they can restore function, and they can help, reduce mania and the distress of the illness burden.
Yeah. And what about in the depressive phase of things? How do we think of that? I mean, we've already talked about some of the complications with these medicines that we usually use for depression that sometimes can make the mania problem worse.
Yeah, I think there's careful prescribing. It doesn't mean that just because you have bipolar 1 doesn't mean that we'll never treat depression ever again, or that like we have to avoid it. There's certainly medications that are less likely to induce mania. And what's really helpful about the mood stabilizers is they do that. They stabilize both sides of things. So lithium has been really known to have an anti-manic quality, but it can also help with depressive phase as well. And just Depakote 2 really can help on that depressive quality. And then you augment with other things. There's definitely medications that can be helpful in adding to what's there.
Now, this gets a little controversial with medicines, because I think there's different perspectives about how one would do this, and maybe a more American way and a more European way. But to what extent do we see the use of these medicines in outside of the active problematic symptom states, like a manic episode or depressive episode? To what extent do they keep mania or depression away? Right? Because that's always the hope, I guess, in psychiatry. They say, take this and it'll keep it away. But is that true for everybody, or what's the evidence for that?
Yeah, I think what you're describing is like a maintenance phase. Is that kind of what you describe?
Yeah, like a maintenance phase. How do you treat then?
Yeah, I think you work with your provider. I think you work collaboratively. I don't think there's anything controversial about saying like, is this something that I can change? Is this something that can be different for me? I really think I've done pretty well at this dose. My levels look pretty good. Is it worth? I see it's maybe worth trying something different. Or I heard about this new medication.
So if the goal is to sort of get mood into a kind of a manageable zone that isn't too high and isn't too low, how do we know what that is?
We ask, right? You talk with the person, and they talk about how functional they are in their life, and how their sleep is, and how their relationships are, and you take it from there. I don't pretend to be paternal around it or coercive that this has to be your lithium dose. I just ask people how they're doing and go from there, because at the end of the day, that they have the autonomy to do what they want with their bodies, of course. And so they might say, forget you, and start doing their own process and do something different. So it's always the relationship that seems like the most important thing.
Yeah. And if there was one thing that you really wanted a a psychologically minded person like our listeners to know about bipolar disorder and really remember and take with them, what would that be?
I would end with like the provision of hope, ultimately, that bipolar disorder, if you're listening and maybe you're thinking that might be something that you're experiencing or someone in your life is experiencing, that there is hope, there is treatment available, and that you are seen, you are heard, you're believed, and that your efforts towards wellness are really important, and that the illness itself doesn't have to be the central story of your life. I think what's important is to recognize that you can recover, and that there is the possibility of repair. There's a possibility of restoring the relationships that might have been ruptured. There's possibility of repairing finances, and I've seen it over and over again. Like, this is not a hopeless zero-sum game, that once you have a manic episode and you've done maybe some disruption to your life, and maybe you felt like you've really made a mess of things, you can certainly find a way forward. I think when I think to this idea, I'll let someone that has experienced bipolar speak for themselves, and that's Dr. Jameson saying that I'm not ashamed of having this illness. This is what I have and not who I am.
Well, Matt, Dove, thank you so much for joining us on Unravelling today.
Thank you.
So thank you again to Matt Dove for that wonderful interview and all of that really enlightening information. And joining me again is Mary, who's been with us and listening along.
Mm-hmm. And it was enlightening. I learned so much. I really thought that bipolar disorder was just about the highs and the lows, but learning about the spectrum of symptoms and that sleep is involved was a big thing I did not know. And just ways of thinking, relationships, there's so much more complexity to it than I think what most of us are exposed to.
It really challenges, I think, our assumptions about a lot of things. I mean, I think that people can really, because of an acute symptom, behave sometimes in very, very different ways than they would normally, sometimes really contrary to their values or usual ideas about things. It's really quite complicated, and people can end up in really rough and difficult situations because of that, and as well as sometimes have powerful experiences of creativity and connectedness at times in certain phases of the mania or hypomania.
And many people are living with it and doing just fine after maybe years and years of seeking treatment and taking quite a long time to get diagnosed.
Absolutely. I would say that even though it might sound really different to folks that are not familiar with this, that it would be good to think about people with bipolar disorder as being everywhere in all walks of life. And it is a thing that can be lived with and managed and treated really quite effectively, not always without certain kinds of pains and challenges and difficulties, but it definitely is a thing that people are living with all the time.
Yeah, he had a great message of hope at the end of, recovery is possible and you can repair those relationships that maybe were fractured because of this disorder. Absolutely.
And some of my favorite therapists I know, colleagues, have had personal experiences in bipolar disorder. And so absolutely.
So our thanks again to Matt Dove, and thank you, Kurt, for bringing us that great interview.
Oh, and thank you, Mary, and thank you, audience. And I hope folks will join us next time for what will be the start of a very special trio of episodes that is going to be a lot of fun and a wild ride.
We'll see you then.
Unravelling is brought to you by Brattleboro Retreat. Our producers at Charts and Leisure are Andrew Atkin, Hans Butow, and Jason Oberholzer.
And you can find us on social media by searching Brattleboro Retreat. Brattleboro Retreat is committed to exploring diverse perspectives on mental health. While we invite hosts and guests to share their insights, the views expressed are their own and do not necessarily reflect the policies or positions of the hospital or its staff.